5 after 12. The news has been full recently of all sorts of disasters, fires, floods, hurricanes, tornadoes, mass shootings. I mean, it seems to be just one thing after another. And when I trained, we didn't really think much about these things. We just sort of took them as they came. It's obviously we have to be prepared for this. Angela, what is your final formal position now? You're like director of the committee, God?
No, I run the disaster preparedness course for the ER residents, but I'm just a regular old assistant professor.
Anyway, we're going to talk about what really is in place in Louisiana as opposed to what we think might be in place. So, Angela?
Hi, for those of you who don't know me, Angela Cornelius. I'm in the Department of Emergency Medicine.
We need the mic.
Can y'all hear me? I'm generally pretty loud. Yeah, I've found that I don't, and that when I teach Stop the Bleed classes, the police officers are like this because I'm yelling at them. Just happens. But anyway, so we're going to talk about mass casualty preparation in Louisiana. And to explore mass casualty preparation in Louisiana, we really need to take a big overview. So we're going to start with the federal government and kind of where it evolved from and how it ended up in Louisiana. So why am I qualified to talk about this? I actually fell into disaster stuff when I was a resident. I was a leadership and advocacy fellow in Texas, and one of the things was they wanted to get you ready for your fellowship for the American College of Emergency Physicians, so you have to be on a national committee, and they said pick one. The president's from Texas, she'll give you whatever you want. So I chose disaster because it sounded kind of cool, and I've been on that committee for the better part of 10 years. So some objectives. First, what is an MCI exactly? And then let's talk about the epidemiology and then how this mass casualty preparation has evolved in Louisiana and honestly in the United States. How our current mass casualty system functions, and then current Louisiana MCI levels. Some other things I'm going to touch on are research that has really been done for trauma, but it's very applicable for mass casualties. We're not going to get into any debates about whether this research is right or wrong, just sort of where it's going and what we're looking at. So why? Why am I even talking about this? So these are mass casualties that have happened in the last 14 days alone. So a rap concert in Italy, 6 dead, 50 hurt because people stampeded. And then you've got a semi-truck was going the wrong way and hits a school bus full of basketball players. You've got a factory that explodes in the Dominican Republic. Only 3 dead, but 44 injured. And those of you who've been to the islands know what I mean when the healthcare system always makes me a little nervous to be out there. Like, I'm super careful because I do not want to end up in their hospitals. It's just scary out there. Tornadoes. I had no idea until I looked this up. There were just a set of tornadoes that touched down in Illinois, injuring a whole lot of people. Plane crashes into a Florida autism center, kills the 2 in the plane. Luckily didn't kill anybody in the building, but it exploded. This is in the middle of Fort Lauderdale. And again, another school bus ran off the road and had a bunch of people injured. So, okay, we don't really have those issues, right? Well, I beg to differ. We have major concerts, this one coming pretty soon. We have school buses. We have school bus crashes here. Luckily, nothing that's involved hemophiliacs or really very much in the way of injuries, but still. We've got factories here. Tornadoes. And those of you who don't know, this is the top of Texas Street. This is First United Methodist. The steeple is missing. It was actually on somebody's car with them in it, I believe.
And we took care of that guy.
Yes. And we have planes. We have really big planes here. And things that may or may not be at Barksdale. But let's talk about some Shreveport specific hazards, because until I started looking into this, I didn't really know a lot of this. We have 9 freeways that run through here, and those freeways carry toxic elements, including nuclear stuff. And some of it, the nuclear stuff for military is going to be very well protected. That I'm not so worried about. What I am worried about are the x-ray trucks that go out to these oil fields and x-ray. They have unprotected radiation in those trucks. And it's just a panel truck, like an F-150 with a panel truck on the back of it. It's kind of scary to think about that. We have 2 major airports. We really have 3 in CADDO Parish. There's one in South Parish that's a little strip. But we have 2 major airports. We've got a river through here. What if somebody loads a barge up with a bunch of explosives and explodes it outside a casino on the river on a Friday or Saturday night? I'm thinking that would not be very good. We have Barksdale and the things that they keep there. We have 10 railway lines through here. I didn't realize till I looked it up how many railway lines we did actually have. And then the one that scares me most of all. This is Napa Shreveport. Does anybody know what that is? That's a pipeline that runs from Shreveport Regional Airport out to Barksdale Air Force Base that carries Jet A fuel, running almost right under our feet. Kind of scared me when I was like, whoa, okay, that could be really bad if that lights off somewhere or ruptures. So I'm going to set the scene for you here. So imagine this scene as you're watching this. Imagine there's no coordination with the local fire department. There are no pre-meetings. There are no immediate meetings before. There are no Las Vegas assets staging on this scene. There is a private ambulance company that manages the concerts for these people. However, it's still kind of, let's see if I can get this to work. Oh, there we go. There we go. This is Mandalay Bay and the Country Music Festival, and you can just hear the shots ringing out. So because they weren't really plugged in with the community, the hospitals also weren't really anticipating this possibility. And they might not have done anything anyways, but they might have. And that type of thing keeps disaster people up at night when you're having a regular Saturday night and all of a sudden 200 casualties are coming your way. So you can just hear the pandemonium. People are panicking, and rightfully so. I would be too. So, and this would be from my standpoint. So you're in the ER, it's just a regular Saturday night, you know, about half of your 60 rooms are full, some are ready to be admitted, some are ready to be discharged. You start noticing a few more people rolling up in your triage, because that's how it's going to happen. People are going to self-transport, and honestly, it's a good idea. And then the red phone rings, and those of you who've been in the ER know the red phone brings nothing but pain. It is never a happy call when they're calling you on the red phone. It's always some pain coming your way. And you get the report from Biotel that there's been a mass shooting at a music festival near you, and you have estimated 200 casualties. So what happens at this point? You know, first thing I'm going to do is take a deep breath. But so you may be looking at a scene like this. This is one of our airport drills and some military drills. But so what is exactly a mass casualty? Anybody? Bueller? Anybody? All right. So it's an event that's going to overwhelm the healthcare system with a number of casualties in a short period of time. So what our mass casualty might be is going to be different than what Homer's mass casualty is going to be different than what Alexandria's mass casualty will be different than what, say, metropolitan Boston or Chicago can handle, just because of the level of resources that they have versus the level of resources that we have. So is there a specific number? It's not. There is no specific number. You know, what may overwhelm us may be 8 or 10 reds versus what may overwhelm Minden is a single red. So it depends on what you've got in your cache of tools. So here's some terms to know as we go through kind of the Louisiana stuff. So ESF 8, that's Emergency Support Function 8. The DRC is going to be the Designated Regional Coordinator, HCC Healthcare Coalition, and then Hazard, Threat, and Risk. I use these interchangeably. I did a thing for my federal deployment team the other night, and apparently the government's very picky about these are very different terms. I use them interchangeably. So the epidemiology. So back in 2010, they looked at the National EMS database, and there was almost 10 million calls that were documented in there. Of those, roughly 14.5 were mass casualty incidents, and by the time they pared it down for multiple agencies reporting the same mass casualty, you ended up with roughly 10,000 MCIs in a year. I don't know if that's a lot, if that's a little, seems like a lot to me. But so, where did these happen? Interestingly enough, 39% happened right here, where 19% of the population lives. I have no idea why. And then urban, almost 61%. No shocker that highways were involved almost 60% of the time. And also no shocker that 63% of the time it was motor vehicle collisions. And that's most of what we see. So let's take a big 50,000 foot overview of how we got to where we are now. So much like everything else in disaster preparedness, there wasn't a lot until this day right here. 9/11 changed everything. And then the anthrax attacks happened, and so a group of stakeholders got together and they said, we are not prepared for bioterrorism. And so they came up with this hospital preparedness program. Interestingly enough, that was September 11th. By early 2002, Congress managed to get this together. So they can do things when they really want to. So they put out this hospital preparedness program, but it was a bioterrorism hospital preparedness program. So they put a little bit of money into it, only like $125 million. So that's not a lot, but the ideas that they had in the early program is they wanted to build capacity for treatment. They wanted to emphasize activities such as decontamination, having people learn how to do this appropriately. Pharmaceutical caches, National Strategic Stockpile. We do have one right down the street should we need it. Identifying hospital bed surge capacity. And this was kind of interesting because nobody had really spent a lot of time looking at that. You know, how do we determine where we can send people? Because the level 1 or the 2 level 1s or the 2 level 2s cannot take everything. You have to figure out how to get these patients to other places. And then you want to train providers in the diagnosis of diseases caused by bioterrorism. And everybody was thinking about anthrax. You know, nobody wanted to miss the lobar pneumonia that actually died on you 12 hours later because it was actually inhalational anthrax and it was not just a pneumonia. So 2004, the emphasis of the program is going to shift. So before it was capacity-based, bioterrorism focused, people could just buy supplies and that was it, you did good. Well, then they wanted to be capability-based, all hazards. So it became where you needed to demonstrate you could use the supplies, which makes sense to me. Because just because you have it sitting in a closet doesn't mean you know how to use it. So 2006, you got the Pandemic and All Hazards Preparedness Act. They're starting, you notice it's all hazards now, so they're starting to shift. And they created ASPR, which those of you who have anything to do with deployment teams, ASPR kind of runs your life, but it's Assistant Secretary for Preparedness and Response. And this person acts as the advisor to the Secretary of the HHS on all matters involving public health, medical preparedness, disaster preparedness. So 2007, the HPP was under what was called the HRSA, which was the Health Resources and Services Administration. Well, they decided to move that under ASPR, which actually made sense because now you're putting this person who handles all of the mass casualty, the pandemic, any sort of disaster preparedness type stuff, and you're putting it together with that. So that kind of makes sense that you're putting them together. Go back. So just some background on Louisiana. We do have our own hospital preparedness coalition, and we're divided into 9 regions, and we'll get to that in a little bit, kind of where these regions lie. So 2001, you got the 9/11 attacks, and then in the middle there you have the HRSA grants for healthcare preparedness and sea burning disasters, and Louisiana starts looking at identifying regional coordination structures to link these hospitals together and to get representatives in the field. Katrina and Rita. So Katrina highlights the need for this regional structure because what you had is you had stuff going on in New Orleans and people in Baton Rouge didn't know what was going on in New Orleans and people in Shreveport didn't know what was going on in New Orleans. It was just sort of disjointed. There was no way to tell what they needed, what they had, what we were really going to be able to help with. So Gustav and Ike in 2008 test this. They get a coordination system together and they test it and it works well. So we're like, okay, we're on to something here. And then 2012, I was in residency 2008, 2009 when we had all the pandemic flu, particularly the swine flu that actually took out our entire DA's office. We ran out of ventilators in Corpus Christi during this time period. So it was bad. Like we had plans, luckily it waned off, but we had plans to bring the military in with Western shelter tents and ventilators because we were running out of ventilators. We had nowhere to put these patients. And we didn't have ECMO capability either. So at that point, they go, we need some crisis standard of care guidelines because how are you going to handle this? You cannot give the same amount of care in a crisis situation. So let's talk a little bit about crisis standard of care. And to me, the best way to talk about it is just to read what the Institute of Medicine actually says about this. So it's a substantial change in the usual healthcare operations and the level of care it is possible to deliver. And this is made necessary by either a pervasive or a catastrophic event. So this change in level of care is justified by the circumstances and formally declared by a state government. And that it's going to be in effect for a period of time. So once the formal declaration occurs, then we have certain legal rights that protect, particularly us as physicians that have to make these hard decisions. None of us want to make these decisions, but they're going to have to be made, and let's be honest, we're going to be the ones who are going to have to make them. So the standards of the crisis standard of care, and they don't lay out what you should exactly do, but they do lay out some tenets that your state needs to go by. So fairness. As much as you possibly can, you need to make it fair, where even the people who are not getting the resources can understand the logic of how it got there. It needs to be equitable, so it doesn't matter who you are. It needs to be equitable person to person. It needs to be transparent. How are you coming to these decisions? And this is where you get into sticky situations that the CEO's daughter should be a black tag. That's a hard decision to make, particularly if you know this person or your next door neighbor's daughter is supposed to be a black tag. How do you handle that? So you try to make it where it's transparent. It needs to be consistent. So it doesn't matter, age, race, socioeconomic status, any socioeconomic status, sexual orientation, anything. It should be equal across everybody. And then proportionality. So proportionality, it needs to be proportional to the level of the disaster. Just because you have an MCI and you have like 5 patients, well, maybe you ought not to be thinking about crisis standards of care because you can probably absorb those 5 patients and do fine. But if you have 500 patients, clearly that size is going to be something you're going to have to think about it. And then accountability. The people who are making these decisions need to be accountable for this. Need community and provider engagement, education, and communication. Now, I'm not sure, maybe all of this has happened before I ever moved to Shreveport, but I have no idea if anybody in this town, if it's ever been talked about what our crisis standards of care in Louisiana or in Shreveport are. I'm not sure about that at all. And then you need to have the rule of law, to have the authority and the environment to be able to make these decisions in safety. So back to the timeline, and then in 2017, 2018, CMS Emergency Prep Rule comes out and healthcare coalitions. So they're moving more towards having sustainable healthcare coalitions. And once again, the grants are shifting focus. So this is kind of what our ESF8 network looks like. So at the top is going to be the LEAD, the Louisiana Department of Health. Underneath that, you have your designated regional coordinators for hospitals, public health, EMS, nursing, even nursing homes get in on this. And then on the bottom level, you have the actual facilities. Now, our hospital DRC up here is Knox Andrus, and he is all over this. I've actually been in his office when a mass casualty was declared, and it was amazing. Like, his phone is blowing up, and his computer's lighting up, and it was like being in a casino. It was kind of interesting. Oh, go back. Yep, there we go. So these are our 9 regions. And they're sort of logically made. I don't know how, 1, 2, 3, but anyways. But you can see, they're pretty balanced as far as population. Obviously, New Orleans has a significantly higher population, so it's a much smaller region. And that kind of makes sense, because you're kind of trying to divide things up, whereas we have a whole lot of parishes under ours, but we have relatively small population for the amount of land mass we have. So how does our system work? Well, we've got the Louisiana Department of Health Center for Community Preparedness, and they're going to spearhead this, and they're going to coordinate the state's response for all types of disasters: natural disasters, pandemics, floods, plant explosions, anything you can think of. And then Learn is going to come in, and Learn acts as almost the feet on the ground. They man a 24/7, 365 a day call center, and they sort of act as a central data repository, which is kind of nice because there is one number that everybody can call. And then Learn can put the data together and push it out to all the stakeholders so everybody's getting the same picture of what's going on, instead of me talking to one guy in New Orleans and you talking to another guy in Baton Rouge and getting two totally different pictures of what's happening. Learn kind of helps coordinate everything for that. So that's really nice. So MCI levels. For our state, Learn kind of sets them. A level 1 is going to be local resources, 5 to 10 patients. We actually probably have a lot more MCIs that are actually declared around here. Triaging, we're not going to talk a lot about triaging. Triaging is going to be red, yellow, green. We do follow the START triage guidelines here. There are some people who love SALT. To me, it's exactly the same thing. So I'm not going to get into a debate about that. There's some very high emotions over that at the national disaster level. So level 2, you're going to have local resources. You may have to pull in a few extra local resources, which is 10 to 20 patients. Local hospitals are notified. Maybe you might go into like the next parish. If there's another hospital, like, hey, we may need to send you some greens. So level 3, you're going to have multiple regional resources and responding agencies. So this is when you get to 20 to 100 patients. So we're going to start pulling in fire districts. Valentine is going to start showing up. Maybe even get some units in from Wascom. So this is a little bit bigger situation. And they're going to notify regional hospitals and or adjacent regions. So for us, they'd probably notify Tyler. They'd probably let Alexandria know. So a level 4, 100 to 1,000 patients. And I can't even imagine the pandemonium with just a level 4. You're going to require multiple resources, and these are going to take a while to spin up. Like they asked me the last time I gave this lecture, well, how much resources can we spin up in a short period of time? I say within 10 or 15 minutes, we can probably spin up. We have 10 ambulances in Shreveport, which, by the way, is 2 below what the National Highway Transportation Safety Agency says we should have. But we have 10 ambulances. We could probably spin up half of them in short order. We could spin up quite a few Valentine assets, but again, that's going to take some time. That's maybe 30 minutes, 45 minutes down the road. And then what if Shreveport's running all medics out? That happens pretty frequently, a couple times a week at least. At a level 5, statewide resources. We're going to call people from everywhere. This is a big deal. This is a Katrina or something along those lines. Greater than 1,000 patients. All hospitals are going to be notified statewide. I would guess where we're at, we're also going to notify Jackson. We're also going to notify Little Rock. We're going to notify Dallas. We're going to notify Houston. Let's be honest, we can get people to those places faster than we can to New Orleans. So I suspect we will notify multi-state resources for us. So how do we know the hospital's capacity? Well, this was what I was talking about when I was in Knox's office during the MCI. They have this MSTAT system. So the nurse managers go in and update this every day, kind of what your status is, how you're looking as far as beds, your capacity. When a call goes out, there's been an MCI, they go in and update what they can take. So university might update that we can take 4 reds, 8 yellows, and 15 greens, or some variation of that. So every hospital notifies what they can accept, and they actually on scene will be notified by BioTel what we can take, and they will help direct everything. And we'll get into exactly how that would happen here. We also have the data cell system. So it's a data management function, but it basically enforces reporting requirements, which is kind of nice. It has a little bit of some teeth to it. So what do we do here in CADDO? So the people who get on the scene first are going to have to make a survey of this. They're going to have to figure out how many casualties we potentially have, and they're going to have to maybe immediately declare an MCI, maybe only set up triage and kind of get a better idea of what we have. They're going to let BioTel know that they've got a significant incident. So BioTel is going to tell hospitals, is going to tell potential private agencies, fire districts that they need to potentially be aware this is coming. And then at some point, there's going to be an emergency medicine declaration. When they do an emergency medical declaration, that's when things start happening. They spin up the EOC. Now we're talking about, it takes a while to open the EOC though and to get people there. So you're looking at 45 minutes to an hour. That's why I always say as an ER doc, you need to know the first hour of a mass casualty. You need to be able to manage it because you're going to be the person in that ER that is managing that mass casualty until that EOC gets up. It takes time to get people in, and disasters never happen at 8 to 5 when all the administrators are here to handle all this stuff. This is going to happen at 3 a.m. when you're sleepy, and then they're going to implement stuff, which they're going to be doing mass casualty triage. They're going to have a couple of different officers. There's the triage officer that sort of takes the big overview of everything and directs where everything is going. He's in constant contact with the EOC and BioTel on the scene. He's not actually doing the triaging. There's the extrication officer, though, that's going to be doing the actual triaging and the moving of patients from one place to another.
Andrew,
So-
where do those people come from?
Depending on the first agency on scene, most likely in this area, it's going to be either, if it's across the river, it's going to be Bossier Parish Fire Department, or it's going to be Shreveport Fire Department. Now, in the fire districts, if it happens in Fire District 5, it may be Fire District 5 that takes the lead on this.
So no matter what team goes out to the scene.
The EMS providers do. In some situations, there have actually taken ER docs out to manage the scene. But you're taking a bunch of people who don't know much about mass casualty. I mean, there's a small percentage of us that do, but a lot of people don't. And so that's not the best situation, is to put somebody who's untrained in mass casualty on a mass casualty scene. So most of the time, it's probably better to have them at the hospital managing the flow of what's going on right there in their facility and let the EOC handle outside the door. So these are our priorities, which is pretty in line with everybody else. Highest priority is going to be your reds. These are people who are in imminent danger of dying, like our level 1 stats. Second priority is going to be the yellows. They're a little bit sicker, they're maybe teetering, but they're not quite there yet. Greens, sometimes they may not even be transported, they may self-transport. These are the ones that we're going to say, hey, if you can walk, you can hear my voice, get up and come over to me. And most of those will be triaged as greens. So I thought this was interesting, just as a funny aside, since we've gone through all this serious stuff. So this was a chart from 2007-2009 HHS and ASPR report. Notice up here, apparently Shreveport doesn't actually exist, despite the fact almost all those hospitals are in Shreveport right there. I thought that was kind of funny in a typical federal government. Oops. But so let's look at some of the research. So numerous lessons have come from combat casualty care in the field. Like, we know that. So looking at blood stuff. And the first really good one I found was Proper, who talked about, he basically took mass casualty, there's 3 mass casualty incidents managed, I think it was in 2008 out of Balad. And they looked at what the resource utilization's actually going to be for a mass casualty incident. So they found that roughly every person is going to need 3.5 units of blood. 48% are going to need blood. Of those, roughly, they're going to need 3.5 units apiece and almost 4 of plasma. 76% required immediate operation upon presentation. So that makes you kind of crazy. If we get 100 patients, thinking that 76 of them might need to go to the operating room immediately, we don't have 76 operating rooms. So that kind of makes you think about that. It was 67. And then of those people, almost everybody got 4 procedures apiece. 50% had to go to the ICU, and almost 50% required vent management. So again, think about how many vents do you have in your hospital. And then it looked at just some other like ICU day utilization. So that was kind of nice. Like, that's out of the field, but it gives us a good idea with a real mass casualty what we might expect. So then they started looking at ratios of blood products. And I know this is all kind of, ratios and balanced resuscitation, but my argument is how this relates to mass casualty is if I can give the right amount, I can hit that sweet spot for the amount of blood, and I'm not pouring 40 units into somebody. I may be pouring 4 units into somebody. Well, then I have 36 left to treat 5, 6, 7 other patients. So they started looking at that. This is one of the first articles looking like about balanced resuscitation in the field. And then they started looking at, well, can we use TAG to do this, which is actually what a lot of times they are doing upstairs. We don't have a TAG in the ER, unfortunately, but they're doing this upstairs in anesthesia, and it does guide resuscitation pretty well. And then kind of where we are now is we're kind of back to whole blood. And I'm not going to argue good, bad, although I am a firm believer that salt water is for making pasta, not for resuscitating people. So, but think about this. What about the walking soldier bank? What if we had something here where people registered? We know after a mass casualty, what do people do? They want to do something. They come out and give blood. So what if we had a registered group of people that were interested in that? It's something to think about, some potential civilian ways of doing this, because they do have all these soldiers are blood typed, and they will, sure enough, use whole blood transfusion out of these soldiers. So another thing that came out of field that is very, very applicable to mass casualty, tourniquets. Going back and looking, East Ridge went back in 2001, between 2001 and 2011, and judged that roughly 24% of battlefield injuries were preventable. And primarily the issue was uncontrolled hemorrhage. So it seems to me like a tourniquet would work great. So they started working on that. And this is one that looks at the CAT tourniquet and just showed that it did provide a survival benefit, which makes sense. If you make people stop bleeding, they get to keep their blood. I think they probably do better. So also, Cotwall went back and looked at tactical combat casualty care, which is military's, what they use for their medics. And that they had essentially eliminated preventable battlefield deaths just by looking at the 3 things, and TCC, if you're not familiar with it, it looks at rapid hemorrhage control, it looks at relief of tension pneumothorax, and then relief of airway obstruction. And that doesn't mean placing a tube in their throat. That means maybe letting them sit up. Let them sit up, let them clear their own secretions. But the vast majority of people that were saved by this course were saved by hemorrhage control. So it does work. So, Sandy Hook, 2013. A whole bunch of people met up in Hartford, Connecticut, and it was, everybody, military, police, fire, EMS, trauma surgeons. And they said, we've got to stop this. We've got to come up with something, because clearly laws are not working to save people's lives. We do, but can we save more? And so the Hartford consensus wanted to focus on public education and materials, getting this out to the public, empowering people to save others' lives. And then they wanted to respond first care providers. Now, I actually saw a lecture by the he was the Israeli Minister of Public Health. And they do interesting things. They teach through games in kindergarten. They teach children how to put tourniquets on people. They also empower their people. What they say is, if you see something, do something. And I don't mean go and call the cops or anything. No. They actually empower them to jump on that person and try to prevent it. And even over there, they say, even if you lose your life, think of how many you save. So it's really interesting. If you all ever get a chance to, I don't remember his name right off the top of my head, but he was an amazing speaker. So 2015. They roll out the National Stop the Bleed campaign, which we still use. We actually teach a version of this to police officers, and we've had 15 or 20 tourniquets placed where it's potential that patient would not have done as well had they not placed those tourniquets. So it does work. So 2016, the American Academy of Orthopedic Surgeons convened a meeting with a whole lot of other surgeons in Chicago, and they basically are saying, we need to advocate for the end of these restrictions on gun violence research. We need to roll out the recommendations of the Hartford Consensus. We need to expand research looking at these mass casualty incidents. So things are starting to shift. They're starting to move. So where do we need to go? We need to thoroughly examine each of these events for lessons learned. Maybe lessons that we did learn and we forgot about. And we need to continuously prepare for the next one. And I'm telling you right now, I'm not trying to scare you, but we're blessed here in Shreveport. We've not had any of these incidents, but it's coming. It may be at the Indy Bowl. It may be the next pageant that we have that's nationally televised. It's coming. It's just a matter of time before we have an incident here. We need to make sure we're partnering with our military colleagues. They have an amazing fund of knowledge, Now, some people say, oh, but it doesn't cross over. Maybe, but I think that we can still learn a lot from them to improve what we're doing in civilian trauma care. Trauma research funding, we need more of it. That's just all there is to it. We need to work on, we've got the compressible hemorrhage down, but now what about the junctional hemorrhages or the non-compressible hemorrhages? We really don't have anything other than packing the wound for those. So maybe somebody can have an outside of the box type solution for that. And then we need to educate, equip, and empower our public. That's going to save lives. I don't know if any of you have heard any of they weren't videos, they were recordings from inside the Pulse nightclub, particularly in the bathroom. You can literally hear people bleeding to death. And I don't mean you hear the blood dropping on the floor. You hear them, you hear their mental status changing, you hear them get thirsty. You know they're going into stage 1 shock, and you can hear them go into stage 2 just by their actions and how they're acting. Could those people's lives have been saved? Possibly. I mean, the after action report says that there really weren't any that could have been saved by tourniquets. My argument is even one, would that have been a benefit? I think so. Thank you very much for your time, and any questions?
A couple questions, just kind of about our capabilities here, and going back to your red, yellow, green, black tags. You know, the difference between your highest priority and your lowest priority is sometimes a thin line. Like if you and I were out in the field with 100 gunshot victims and had one ambulance, we wouldn't put the gunshot to the head person, on that ambulance. So do we have our triage nurses, or do we have a set of nurses that are especially trained in that kind of triage should we have an mass casualty event?
We triage every day almost exactly like that. We use 1 through 5. But it's very similar to that. Are our nurses specifically trained? Not so much.
It also seems
it's mostly our EMS providers that are trained to do that. And that's really going to get them to the hospital. We're going to re-triage when they get here.
It also seems like the higher level of MCI you have, that changes. You know, if we had an MCI 1 or a small, 5 people injured, then the gunshot wound to the head is the top priority. And we're all focused on that one. But as it gets higher and higher, that gets lower and lower.
You're right, and your priorities, your crisis standard of care will change depending on what you have in front of you.
So it's not a lengthy discussion, but in the trauma nursing core course, which all ED nurses here are required to take, there is a whole chapter on disaster preparedness, and we do go over black and yellow and green and what that means. And
they do, but I don't know that it's really.
It's not anything you could call like I'm trained in it, but at least there's an exposure.
No, there's familiarization, so like they understand what it means, but would I call that?
The other thing is, I always get these annoying weather and Amber Alert things on my phone. Does one of those go off when one of these happens?
That was my question, is how do you mobilize the troops? Because the operator right now could not tell you who's on call for any given service with regular accuracy.
We've actually discussed this. I think Shane and I actually discussed this, that we have a communication problem within our own hospital. Communication is like 101 for disaster management. Like that is, I'm going to be honest with you, like any sort of mass casualty is going to be pandemonium and chaos. It's just if you can somehow make some organization of it, it will make it better.
May I make a suggestion? I have 3 kids that are in orthodontics right now. I get regular text messages demanding that I say if they're coming to their appointment or not. And they're like clockwork.
Yep.
And it synchronizes and everything. I think there's already a system in place, and we all carry these things around, that if we heard, hey, there was something at whatever, and your phone goes off and it texts us like, you're on some predetermined list. Yeah. It would be easy to do.
No, I agree. We do have, Louisiana has volunteers, Louisiana Volunteers in Action, the LAVA group. They do some of that, but I don't find that they're super effective. Honestly, like I've already been notified by my federal team about what's going on before I ever hear anything from LAVA. So we definitely have places to work on, for sure.
You mentioned earlier this coming closer to home, and for those that are in the PIPS committee, you know, we heard Patty talk about the platelet shortage and where we're headed with this. So we have been indirectly effective because when Natchitoches had the 3 individuals shot the other day and 2 killed on scene, all 3 of those patients were scheduled to go to Rapides, and Rapides diverted them due to the fact of not thinking they were going to have enough platelets on scene to manage those patients.
And that's a valid reason to
Yeah, they have the
send them.
staff to manage, but not the platelets. So it's,
We have a